Centers, Jackson West and Jackson South. Busy woman, right? So she's here to talk to us about patient selection for stroke, mechanical thrombectomy, patient selection. So thank you, Dr. Gordon Perue, for organizing all this workshop, and it's a pleasure to work with you. Thank you.
Thank you again, everyone. Nice to be here. So this morning we're going to talk about patient selection for mechanical thrombectomy. Okay, so I don't have any conflicts of interest that are relevant to this talk, but I will be talking about how patients are selected and how this works for your stroke center. So first, we're going to start with the pathophysiology of stroke, and that helps to ground us and sets the stage for why these patients are being selected for mechanical thrombectomy. And then we'll talk about patient selection for those patients who are less than 6 hours of last time seen well, and then for those in the extended window, 6 to 24 hours of last time seen well, and then we'll end with some special case scenarios. So pathophysiologically, and many of you have seen this before, when a stroke happens, particularly a clotting stroke, there's a disruption of the blood supply to the brain, which then triggers a process that ultimately leads to cell death. So if you look at the diagram, you'll see that the absent blood flow leads to excitotoxicity, which leads to free radical mediated toxicity. There's oxidative stress on the cells and cerebral edema. There is ultimately microglial activation, neuroinflammation with further breakdown of the blood-brain barrier, and then ultimately further cell death, which leads into this vicious cycle. We have an opportunity here to disrupt that process. So if that process continues without revascularization, we lose about 1.9 million neurons per minute. Hence the moniker, time is brain. This photo is an animal model that looks at what happens when a blood vessel is occluded. So at 1 minute, the entire brain tissue is at risk of dying, but is not yet dead, and so is called the ischemic penumbra. As time goes by, at 15 minutes, an area of brain cells starts to die. That's the ischemic core. And as time goes on, that core gets larger and larger until it approximates the penumbra. At that point, opening the vessel is not helpful because the brain cells have already died. So our aim is to open this blood vessel, revascularize, before this process is complete and essentially disrupt this process. So there's different strategies we use for reperfusion therapy. Intravenous thrombolysis is key. There can also be intra-arterial chemical lysis. We will focus our talk today on mechanical thrombectomy, physically removing the clot that's causing the obstructed blood vessel. So for patients with acute ischemic stroke, large vessel occlusion, if there's an occlusion of the internal carotid artery, the middle cerebral artery, the anterior cerebral artery, the vertebral or the basilar arteries as depicted in this screen, they have a higher burden of disease and are more likely to have a worse outcome. So it accounts for about 10% of acute ischemic strokes. We think this is an underestimation. And these patients are our sickest of our sickest patients. So even with adequate medical management, 60 to 80% of them will die or not regain functional independence, even with IV TPA. Your bottom left inset is a copy of a CTA that shows a large vessel occlusion. Now, we've known that when a large clot exists, giving intravenous TPA will take time to slowly work its way through that clot. And as I told you just a few minutes ago, time is brain. And so in that time, brain cells are dying, and so TPA, the intravenous version, is not enough. And so many years ago, we started as a society to look at different ways to combat this. Do we do cerebral angiograms with intra-arterial TPA to get at the clot? Or do we try to remove clots? Now, our first attempt at doing that was in about 2012. I mean, at that time, we participated in the IMS3 MR rescue synthesis trial, looking at trying to remove the clot. Now, while those trials were not positive trials, they did give us pertinent information about patient selection and really helped us with the next generation of stents. And so after 2013, we embarked on a second generation of stents, the so-called stent retrievers, and picking the right patient. So the next set of 6 trials, the Mr. Clean, Escape, Extend IA, Swift Prime, and Rivascat trials, really looked at picking the right patients. And so they had very strict inclusion criteria. Patients needed to not have premorbid disability, be able to get to thrombectomy within 6 hours of last seen well. You had to demonstrate the clot on a CTA, and you can give TPA within the treatment window of up to 4.5 hours. And with those trials, we saw a huge benefit. I wish I had a mouse. Oh, I do. So as you can see with Mr. Clean, the number of patients who are able to go back to work or good outcome, what we call a modified ranking score of 0 to 2, was significantly reduced. Increased. So from 19% with placebo up to 32% with mechanical thrombectomy. With the publication of the results of the Mr. Clean trial, the other trials actually stopped and took a look at their data and again confirmed robust evidence that patients had a better outcome with mechanical thrombectomy than without. And so you see with Escape, 53% of patients were likely to have a good outcome versus 29%. With Extend IA, 71% versus 40%. Swift Prime, which was done in the US, showed the same robust benefit. And then Trace trial, the same robust benefit. As a result of these large randomized controlled trials, acute endovascular therapy is now the standard of care for large vessel occlusive stroke. This improves functional outcomes and for the first time showed a mortality benefit with intervention. So now the standard stroke process is that patients should have a CT scan of the brain on arrival. They should be evaluated and determined if they are candidates for IV TPA. A CT angiogram should be done quickly thereafter. CTAs were what was mainly used in these studies. If you're within 6 hours, you do not need to pursue a perfusion scan. You can go straight to mechanical thrombectomy. So how then do you identify who is the best patient for this? And I think of it simply as identifying a target vessel as well as brain tissue that's at risk, brain tissue that can be saved. So when you do that initial CT brain, about 60% of initial CT brains will be normal. There are some things that you can see acutely in a CT brain. This is called the insular ribbon sign. So if you look to the right hemisphere, you'll see there is normal gray-white differentiation. Here there's a loss of that gray-white differentiation in the insular ribbon sign. You can see a hyperdense vessel sign, which can either mean a clot is present or there's slow flow, or you can see early signs of sulcal effacement. The hyperdense vessel sign, while very specific, is not very sensitive. So a CT brain alone is not sufficient to identify a large vessel occlusive stroke. This is a study done by the IST3 group. They not only used their cohort of patients from 2012, but looked at prior studies going back. And what they found was that if you found the hyperdense vessel sign, it is very specific. Almost 100% specific, 95%. But the sensitivity was around 60% depending on the trials. Part of that depended on the site of occlusion. The more distal the occlusion, the further it is down the MCA tree, the less likely you are to see a hyperdense vessel sign. And similarly, the thickness of the CT scan. If your CT is not very thick, 5 millimeters or above, you can see some of these older studies had 10 millimeters cut sections, then you are less likely to see the hyperdense vessel sign. So the sensitivity is about 52% with a specificity of about 94.9, 95%. So now, doing a CTA or some vessel imaging is the standard of care with a stroke alert, identifying these patients. Now, you can do an MRI of the brain, and an MRA can be done. There are some centers that have it very hardwired and do that routinely, but sometimes this contributes to delays, whether it's from screening for metal before patients go into the magnet, or really just getting the patients there. And so we try not to, especially in this 6-hour window, 0 to 6 hour window, waste time on these advanced imaging. We get the CT, CTA. If there's a target vessel, then we go right ahead. So per guidelines, CTA should be done, or vessel imaging should be done. This was first introduced in the 2013 American Heart Association, American Stroke Association guidelines, and then reaffirmed in the 2019 guidelines with the highest level of evidence. CTA is sensitive for detecting a large vessel occlusion, about 92%, and specific, between 82 to 100%. MRA, as I said before, can be used. Just be careful for delays. And these landmark trials used CTA, and so most centers use CTA. So identifying the target vessel. So again, if you're within the 6 hours, you just want to identify the target vessel directly to angiogram, and you do not necessarily need these advanced brain imaging. How do you identify salvageable brain tissue? So the best way to identify is time. And this is a specific definition within stroke, right? So this is last time seen well. This refers to the last time that that patient was seen to be using that neurological function. And this can be different from the time of discovery in some cases, right? So the patient who wakes up with stroke symptoms is actually last seen well or last known well the time they went to sleep the prior night, the last time they were using the neurological function. Mechanical thrombectomy can be done within 24 hours of last seen well. So the guidelines state that patients should get mechanical thrombectomy if they're within 6 hours of last seen well and they meet all of the following criteria. That is a good pre-stroke functional status. There is a causative lesion that you can identify, such as an M1. The age greater than 16. They have a high NIH stroke scale greater than 6. The aspect score, which I'll tell you about in a minute, on CT scan is better than 6. And you can get into that vessel within 6 hours of last time seen well. Again, if they're within 6 hours, you don't need advanced imaging, and if patients are eligible, they should get IVTPA, and this is the paradigm. While those are the guidelines, okay, I'll tell you about aspects first, and then I'll go back to those guidelines. So a moment to pause and talk about aspect score. So this was developed in Alberta. It's scored based on the CT of the brain. And what they were hoping to do, and I think it's helpful for low to middle income countries, is look to see, can the CT tell us, is there already signs of brain injury, brain damage? So the scan, this regular CT scan that you do, is assessed at 2 levels, at the level of the basal ganglia or at the ventricular level, so just 1 level higher. Typically, the CT is windowed to 30-30 or 50-50. And you're looking in these 10 areas. So the M1 division area, M2, M3. You're looking for the lentiform nucleus, internal capsule, head of caudate. You want to see good gray-white differentiation here. Or the insular ribbon. You want to see good gray-white differentiation here. At the level of the corona radiata, you're looking at the M4, M5, M6. If all these levels look normal, this patient is given an aspect score of 10. If any of these levels are abnormal, you'd subtract 1 point for each level. So if the entire area looks dark, then you would subtract these 3, and the patient would have an aspect score of 7, for example. And I'll show you some pictures. So in this plain CT, as you can see good gray-white differentiation throughout. The insular cortex is well preserved. There's no sulcal effacement. This scan would have an aspect score of 10. In the scan below it, you can see a hyperdense vessel sign and early ischemic changes just below the level of the basal ganglia. The higher levels are fine, and this person would have an aspect score of 9. So back to those guidelines. We've now recognized, and there are several studies published, that really we don't have to have all these features. So, for example, patients with an NIH stroke scale less than 6, they still have a large vessel occlusive stroke, they still benefit from mechanical thrombectomy. And so we don't have to have an NIH of greater than 6. For those patients with distal clots, M2 clots, there are now meta-analyses and many studies showing that these patients benefit if you can get to them. What about those patients with pre-existing dependency and disability? Those patients are actually worse if they don't get mechanical thrombectomy. And so the best chance that they have of a good outcome is mechanical thrombectomy, and it is safe and efficacious. And then what about patients with low aspect scores? Now we're saying that an open vessel is better than a closed vessel. And so these are areas that are actively being pursued in research, actively being published about, and I'm sure when the next iteration of the guidelines comes out, we'll talk a little bit more about these extended criteria for mechanical thrombectomy. And the reason, as a community, as a stroke society, we're pushing to treat all comers is because mechanical thrombectomy within 6 hours of last seen well is highly efficacious therapy with a number needed to treat of 1 in 4. Highly effective therapy, more effective than several other therapies we may have in medicine. When the patient is greater than 6 hours from last time seen well, or we don't know when they were last time seen well, then imaging becomes our guide. And so the imaging becomes the best predictor of what is the penumbra. We use CT perfusion to help us decide. Now this can be CT-based or MR-based perfusion. And what you're looking for is a small core and a large penumbra. We used to talk a little bit, especially before the Dawn trial, about a clinical radiological mismatch. And this is where there's a small core on CT or on imaging, and then there's a large clinical deficit, a large NIH stroke scale. And so those were the patients we considered a clinical radiological mismatch. But for now, in the greater than 6 hour window, I think it's now standard that we rely on perfusion imaging. So this can be done with CT. What they're doing is bolusing the patient in the scanner and then measuring these times. So the time that it takes to get to peak concentration and then the time it takes to leave. And there are a few specific times that we use. The time to peak, so the longer it takes to get to peak concentration tells you the vessel is likely to be occluded, right? If the blood flow is low, then that tells you that there's a core area of infarct there. And then we look at the mean transit time, the total time it takes to leave, right? Because if the vessel is occluded, it will take long to get there, and then it will take even longer to leave. And so that's the physics behind the perfusion scan. And you get these pictures. So this is a study from 2019 that was published. And And I like this because you can see that it is a bit of shades of red and purple and orange that you're trying to figure out. So this is the blood flow showing you the small core. And then in this case, it's a bit obvious, the large ischemic penumbra that's at risk. But sometimes in reality, these can be a little bit hard to decipher. And so I'm really excited that they've developed artificial intelligence and software that can help us decipher these cases. And that's the software that they used to drive the DAWN and the Diffuse 3 trial. So in the DAWN trial, they looked at patients who were 6 to 24 hours of last time seen well. So the extended window, they had to have severe strokes, NIH stroke scale greater than 10, and a good pre-stroke level of functioning. Then they demonstrated that there was a causative lesion, either an internal carotid artery, terminal ICA that was occluded, or the middle cerebral artery was occluded. So you have the eligible patient with a target occlusion, and then in that 6 to 24 hours, you want to demonstrate a penumbra. So they demonstrated a penumbra based on RAPID software. And I'll show you some of those pictures. So they had to have a core, that blood flow, that core area of infarct be small. So if you were greater than 80, they wanted an even smaller core, less than 21 cc's. If you were less than 80, they were a little bit more generous and allowed you a core of less than 31. If you had a very severe stroke, they allowed you a core of less than 51. So remember these numbers for core, because I'm going to show you what a rapid perfusion scan looks like in a bit. So the DAWN trial, 6 to 24 hours. The Diffuse trial, conducted around the same time, looked at patients who were 6 to 16 hours after last time seen well. They had an upper limit age cap of 90, NIH stroke scale greater than 6, so not as severe strokes, but they also allowed patients with some disability to be part of the study. Both trials required that there'd be a terminal ICA or MCA that was occluded, and they had a core of less than 70. So a little bit more generous with the core, but saying that they had to have a mismatch of greater than 1.8 for a ratio, or at least 15 mLs of a penumbra to go after. So this is an example of a rapid perfusion scan. You can see a terminal MCA, not terminal ICA, an M1 occlusion. And you can see if each of these brain tissues maps on to the next, you can see that there is an area that is core in pink. That's about 26 ml, so small core, and a large ischemic penumbra, a large area of brain that is at risk. So that animal model we are now able to see in real life. And this person had a mismatch ratio of 6.4, again, greater than 1.8 would be your number. And so this patient was taken to mechanical thrombectomy. Here is another example of a CT perfusion scan using RAPID. And you can see small core in pink with a large area of ischemic penumbra that is at risk. The cerebral blood flow, that's less than 30%, is 44, so less than 50 cc's. Tmax, that maximum time to peak, taking longer than 6 seconds, is 177 mLs with a mismatch ratio of 4. This patient is a candidate for mechanical thrombectomy. Now, you can use MRIs to help you pick patients for mechanical thrombectomy. This is a patient with an area of diffusion restriction, showing you acute ischemic stroke in the left MCA territory. But as you can see, that has not yet arrived on flare. And so this patient would be a candidate for mechanical thrombectomy, as opposed to this patient where you can now see it already starting to arrive on flare. So MRIs can be used. You want to see the image, you want to see the area of restriction on the DWI, but not a corresponding area on FLAIR, telling you that this is brain tissue that is salvageable. So this is another case that was published. Patient had a left M1 occlusion. They used MR imaging and a clinical radiological mismatch. So she had a very small core on DWI, but clinically she had an NIH stroke scale of 20. So they had a clinical radiological mismatch, and they went in and successfully reopened the vessel. So the results of Dawn and Diffuse clearly demonstrated that mechanical thrombectomy is superior to IVTPA or medical management only. So in the control arm, only 4% had a MRS of 0, good functional outcome, versus 9% in the Dawn trial. And I think the ordinal shift happens really in death and disability. You'll see in the control arm, about 70% of patients died versus only 40% of patients in the mechanical thrombectomy group. Similar results in the Diffuse 3 trial, with a significant ordinal shift and less patients with death and disability when mechanical thrombectomy is used, with an odds ratio for a good outcome of 2.8 and the number needed to treat of 1 in 2. So again, powerful and efficacious therapy. So the guidelines now say that for patients who wake up with symptoms, or the last known well is unclear, or they're at greater than 6 hours, mechanical thrombectomy should be considered in those eligible patients based on perfusion scans. And you can use CT or MR perfusion. In the 6 to 16 hour window, there's data both from Dawn and Diffuse 3, because Dawn overlaps Diffuse 3, and so that has the highest level of evidence, level 1A. And then in the 6 to 24 hours, because we only have one trial, the Dawn trial, it has level 2A evidence. This is one example of a stent retriever. You'll see more images of this and actually see the devices today as they demonstrate. So let's talk about some special scenarios. These are actually cases from my hospital just this past month. So this case is a 64-year-old white man. He has a history of hypertension, type 2 diabetes, on oral therapy. He has had a previous stroke in 2012 with residual left-sided weakness, and then had another stroke in 2014. He continues to smoke. Classic, right? At his baseline, he walks with a cane. And he's had some intermittent bouts of dizziness, but didn't think much of it. On the day of presentation, he was initially brought in as a last seen well as 2 a.m. The stroke alert was called at 3 a.m. Yes, I was up. But when I spoke to his wife, she said actually she got home at 12:30 and he was well at that time when he began complaining of dizziness. He had vomiting, vertigo, and then he suddenly collapsed and was no longer speaking. As he was in our emergency room, he became more and more lethargic. I can't tell if this projects very well. It's a little bit dark. But you can see the internal carotid arteries are perfusing with contrast, and the basilar artery is absent. So this is actually an acute basilar clot. And you can see with his angiogram, the vertebral artery appears, but the basilar artery is absent. We actually went in with mechanical thrombectomy and removed the clot, and you can see the basilar artery now patent. And I bring this case to our attention for two reasons. One, he has premorbid disability, so should we intervene? And two, it's a basilar clot. Now, those trials that I talked about before that showed this robust evidence were all in the anterior circulation, right? Terminal ICA, MCA was what we've been talking about. So the basilar artery is a different scenario. The benefits in posterior circulation is not well known, and I'll show you two new studies that have updated that understanding. This is unfortunately my patient. He actually, despite having mechanical thrombectomy, went on to reocclude the vessel and unfortunately died. So posterior circulation strokes are very tricky. These patients have a really high morbidity and mortality rate. So there are two large studies that were just done called the BASICS and the BEST trial. And they tried to enroll patients who are up to 8 hours of last seen well with large vessel occlusion in the posterior circulation, so the basilar artery. And each of these trials, we can debate the strengths of each, but each of these trials on their own did not show a statistically significant benefit, with the confidence intervals crossing 1. However, when we put them together and do a meta-analysis and look at the overall function, we do see a signal of benefit with an odds ratio of 1.62, confidence interval 1.2 to 2.7. So we think that these patients with basilar clots and basilar strokes would benefit more from mechanical thrombectomy, but this is a tough disease, and so it's a special case scenario. The second point that this patient brought up is he had a pre-existing disability. Should we do mechanical thrombectomy? And the odds are that without mechanical thrombectomy, they're more likely to have a poor outcome. And so mechanical thrombectomy remains their best chance of a good outcome. This is just one of many papers that demonstrate that these patients have a better outcome with mechanical thrombectomy. A second case from my hospital was that of a 41-year-old man. He's right-handed, has a history of epilepsy, is functionally independent for all his activities of daily living. He actually presented to us, can you tell I'm doing nights again, at about 11 p.m. And his last time seen well was actually 8 a.m. So he woke up, had a seizure, and noticed after the seizure that his left side was not working. He actually went to another hospital who saw him and said, "Oh, it's seizure, this is a Todd's palsy," and sends him home. Instead of going home, he comes to my hospital instead, and immediately we do brain imaging. And you can see here, there's already subtle loss of gray-white differentiation in the insula, this insular ribbon sign. But otherwise, higher up, his cortex is good. So despite being very late, 15, 16 hours, his aspect score is like a 9. So this is a good candidate. We do the CTA, and he has a distal clot. So he's outside of the window for IVTPA. He actually has a right M2 occlusion. His perfusion scan I have here for you. You can see no ischemic core. Cerebral blood volume less than 30% is 0, but this large ischemic area of penumbra that is at risk with penumbra of 65, and his mismatch ratio is infinite. We took him to mechanical thrombectomy. I say we, but really my team. You can see the tines of the stent retriever in place, and then the vessel is open. He actually walked home 3 days later without deficits. So in summary, how do we select patients for mechanical thrombectomy? So patients present within 24 hours of last time seen well, should have an NIH stroke scale and a STAT CT brain. If we see hemorrhage, then we stop going down the large vessel occlusion pathway. If there is a normal CT brain or no acute changes, then we think about, when was this patient last time seen well? Are they in the 0 to 4.5 hour window? If so, we consider their eligibility for IV thrombolysis and then proceed to CTA. If they're in the 4 to 6.5 hour window, then out of the window for thrombolysis, directly to CTA. If the CTA of the head and neck shows a large vessel that's occluded, then you go direct to mechanical thrombectomy. You do not need to wait for additional imaging. directly to mechanical thrombectomy and then to the ICU. If you're in 6 to 24 hours, then you would go straight to CTA and CT perfusion, or if your institution likes MR perfusion, you'll go directly there, 6 to 24 hours. If there's a target vessel and an ischemic penumbra, then you proceed to mechanical thrombectomy. If the patient is a wake-up patient or unknown last time seen well, and you do the perfusion scan, you actually see an ischemic penumbra, you can consider IVTPA per the wake-up protocol, which is a little bit different, per the wake-up protocol, and then actually give TPA and on to mechanical thrombectomy. So this, I think, is a really nice summary slide, starting with the CT, figuring out where we are for time, and then proceeding to mechanical thrombectomy. And this, I think, is a really excellent guide for selecting the correct patient for mechanical thrombectomy. So these are my references. I now invite your questions. This is my contact if somebody wants to contact me, but I'm going to put it back here because I think this is sort of a pertinent summary slide, and then we can invite questions. No? Yes, Dr. D'Souza.
4.5 to 6 hours, we don't do any additional imaging, just CT and
Correct. Once you're less than 6 hours of last time seen well, anything in this green goes direct to thrombectomy once you can identify a large vessel occlusion.
But you won't use the aspect score.
You can use the aspect score, but honestly, once they're within 6 hours, the benefit is so great, right? Number needed to treat is 1 in 4. And what was the downfall, I would say, of like the IMS3 and the MR rescue is we kept spending time getting more and more imaging. I was a resident and enrolled our last patient in MR rescue at the University of Miami, and we would spend hours in MRI looking for the penumbra to be sure that it's a go. And really what these studies tell us is don't image more than you need to. Time is brain. Get to the Andrew suite. So once you're within 6 hours of last time seen well, you have an LVO, just go. Just go. All right.
Because we're going to Perue from the chat on Zoom.
Oh.
Can you click on the questions maybe? If there's
Sure. Apart from death, what were other complications? So there are other talks today about mechanical thrombectomy that will go into some of the potential pitfalls and how to avoid this, difficulties with access. And I don't want to steal the thunder from many of the talks coming today. And they'll talk about how to avoid these potential complications. Like the next one is called minding the reef, minding these complications. Yes, Dr. Shaw.
So if you don't have perfusion immediately available for the 6 to 24 hours,
I say use the aspects, and the Dawn trial was very helpful because while they did use the rapid software, they used this concept of the clinical radiological mismatch. So you see a small ischemic core on the scan, and the patient has a very high NIH stroke scale. Clinically, they look worse than what the CT is telling you. Then go. And so that was actually, for me, one of the very nice things about the Dawn trial, this clear definition of a clinical radiological mismatch.
how did that match up with perfusion?
So they didn't necessarily do CT perfusion in all of these patients who had the clinical radiological mismatch. But when they did do the subgroup analysis, looking at their outcomes, these patients did just as well as the patients who you had rapid perfusion in. Okay? And the reason they didn't do is because they didn't have rapid for those patients.
And I also wanted to comment.
Sure. Oh, thank you.
So I also wanted to comment on that. So there was this study that was recently published in the fall of 2021. Can you hear me?
Yes.
And it was looking exactly at that. You know, it was a retrospective study of more than 2,000 patients, and they compared patient selection between patients that received an MRI, a CTP, and a CT, plain head CT non-contrast. And then looked at the outcomes of these patients, and they found that there was no difference. You know, these patients were able to be selected, treated based on CT, only with CT, even after the 6-hour window of presentation. So that is that's a huge hope for regions like ours, right?
Exactly.
Because we know the resources. I mean, barely we get a CT scanner
Yes.
in our
Exactly.
hospitals that works, right?
Right.
And then, I mean, not even thinking about, you know, very high-end perfusion studies. So I think that's going to be probably a very good window in terms of trying to understand. That's going to be a highlight. That's what I mean, in trying to understand a little bit more about this population and how we can screen these patients adequately with an aspect score, or, you know, just based on CT, non-contrast head CT, and be able to enroll these patients into trials, I would say prospectively in the future, and hopefully, you know, create a very nice guideline for all of us here in Latin America, you know, in low to middle income countries, so we could actually treat patients based on, you know, the more basic imaging studies.
Actually, that's excellent, because having perfusion is not always going to be available for us. The other thing that I thought of while Dr. Inoa was speaking is MT 2020 has a mechanical thrombectomy app for you to track your number of cases. So that's a nice way of tracking cases going forward. So if we look at CTs and patients selected by CTs and how they do going forward, that, and maybe even the rescue registry, it could be a nice paper to talk to the rest of the world and low to middle income countries about what can be done for patient selection, you know, when you're in a resource restricted environment like ours.
Yeah, I think Dr. Martins, I know she stepped away. She had a conference and another talk. But so she is getting into this, and I believe she'll start the first study in Latin America looking at triaging these patients and treating them based on CT.
Perfect. There's another question Dr. Bruce. Sure. So this is actually being recorded. Mr. Townsend is helping us with recording it. And so after the conference is over, that will be available on the website with a link so that people can go back and watch. And we'll also make the slides available. I'll double check with all my faculty, but I suspect that will be doable. But definitely it's being recorded so that we can have people watch it back at their time and their speed. There's another question in the chat regarding perfusion imaging used in the DAWN and DIFFUSE trials. Automated detection software was used. Is there a difference between this and perfusion imaging in general? So the automated software, the AI imaging, Rapid, Viz AI, whichever of them, they're based on the perfusion imaging. So basically, in real time, what we do is we do the CT, we do the CT perfusion, and then it's a software that works in the background to do this calculation and spits it out to you. So it comes as I get alerts on my phone. There's an app for it. You really get the numbers within 2 to 3 minutes, so you can make a decision quickly. What I like about some of these software and the apps is that the entire team will get the alert at the same time. So both the stroke neurologist and the interventionalist will get the alert at the same time, and the team actually moves together in unison because they get the alerts at the same time. So it's generally speaking the same, except if you just do a plain perfusion scan, you're not going to get those nice numbers and that nice ratio. It's when you do the automated software, that you get the ratio and the numbers that helps us say go or no go.
Thank you. Thanks. And there's something, very basic, if there's a message after this discussion for late presentation. And it is that we're all used to look at the CT scan and we know how to interpret it.
Right.
And we need to remember that patients are different and everyone will have a different collateral score, right? Our brains are going to supply blood flow differently. And when you look at a patient and you look at a scan, it does not matter in reality if that patient presents after 6 hours. If you see a good CT, base CT, just go for it. I think, our guidelines are made for, after a lot of data coming out of developed countries. In our countries, we need to use what we got. And that is your knowledge, your clinical knowledge. You look at the images, and if you think that, based on CT, it is a go, that's going to be a good candidate.
I agree.
This is a very interesting question. And, I consider myself boots on the ground. I've been working for the Dominican Republic for quite some years, even prior to joining MT 2020. And let me tell you what I tell them. Well, it's nice to have all these fancy pictures, and I love to have it. I have ECI in my hospital in the US. It's easy for me to look at a CTP and just look at the ratio, the volume, the Tmax, this and the other. Automated, results right in there for me. I just want to tell you one thing. If you have a good CT scan in front of you and the patient's exam, the NIHSS, that's all you need to decide which patients go for thrombectomy. I know we're good at saying, well, I did this and did the other, and this is what the data shows, but in countries like ours, we need to just do it fast. Time is brain, but also imaging is time.
Exactly.
So to do this imaging, sometimes you have to take these patients out of the hospital, right?
Yeah.
To get a plain CT, to calculate an aspect score, to be able to treat that patient. I gotta tell you, I've been there 2 hours to get that patient back on a CAT scan that there is 2 blocks away in the Dominican Republic. So here is no different because we know the reality in our country. So please remember, it's nice to have these accessories, but think about what's needed. And the only thing you need is a plain CT and your NIHSS. Once you figure out your cutoff on that NIHSS with an aspect score that you consider viable, you go for it.
Perfect.
Last idea, there's a new paradigm, right? Sending all these patients directly to the angio suite.
Right.
So in my hospital in the United
Yes.
States, that's happening. So we're just gonna bypass the CAT scan. We're just gonna go straight to the angio suite. In patients that we think they have a high likelihood to have an LVO. So always think about that. Use what you got.
You mean the CTA?
And the CT. So we're gonna be able to perform the CT right in there on the angio table.
spiral
So
CT.
if we see a good aspect score or whatever that is, we're just gonna go and do it in angio. So that will bypass time, but remember, imaging is time.
Okay.
So you're taking time off.
Dr. Fraser first, and then Dr. Elliott. I love the discussion. Dr. Fraser first.
So, first of all, fantastic talk. Thank you so much. And I'm a little bit scared that I have to follow you. So everything that's been said is true. We have the guidelines that have been put out by large societies based on lots of clinical trials and yada yada. That's not how I practice this, okay? And a lot of our colleagues throughout the United States don't practice it that way. And so I know others were mentioning things like, well, in this country or in this environment or this community, we don't have CTP. I can tell you that I have CTP. I've got, a bajillion CAT scanners. I can run it all day. I barely use it, ever. But because a lot of the scanning is being performed in our communities, and I'll show you the maps, in small community hospitals. And we're making treatment decisions based on a CT and a CT angiogram alone. And what you said is dead on. And we just rebuilt our angio suite and we put a CAT scanner in the angio suite to bypass it all. And so if anything, we're going to less imaging, not more. And the reasons for that is that since 2015, virtually every single thrombectomy trial has shown us benefit, right? So virtually every single thrombectomy trial has shown a benefit. What that tells us is we started out treating the very, top little cherry-picked cream of the crop. And now as we're expanding thrombectomy into more and more people, we're finding that they still get a benefit. And there are multiple clinical trials out there to do thrombectomy on patients who have low aspect scores.
Yeah.
Right? Patients who, you look at them, you're like, oh, that's dead brain. That's not dead brain. That's brain that we weren't able to salvage yet. And so the CTP issue is a major area of contention right now. And if you ask me, my prediction is it'll be gone within the next 5 years. It'll be out. We won't be making any decisions on it. Because there's also data out there that says that it doesn't correlate to
Right.
clinical outcomes.
Right.
So we're using something, we're not sure if it actually means anything, and we're using it to keep patients from treatment, which to me creates an ethical problem. So bottom line is, if you can do less imaging and treat more patients, that's what we want.
Yep. Time is brain. Well said. Dr. Elliott.
I just want to be clear in terms of all that you just shared, especially yourself. This is all after getting thrombolysis. Or you're
If
talking.
they're eligible for
If they're
thrombolysis.
eligible, because you mentioned about just going straight to the angiographic suite and taking pictures when they present. What it is, give thrombolysis, carry them, and actually do the cerebral angiogram in the cath lab.
That's a great question. So for hospitals that don't have that direct-to-angio protocol, so what we do quickly is straight to CAT scan, TPA, we use TNK. So my hospital only uses tenecteplase. So you go tenecteplase on the table or right outside, and then you go straight to the angio suite. But you're right. But remember, those patients eligible for thrombolytics are only the first 4.5 hours. And you know how it is, we rarely get them, right? Same in the United States, it's not common. A thrombolytics use in the nation is less than 2%. 2% of patients eligible get thrombolytics. So yes, so we go for thrombolytics if they are within the window, and then we go for the, thrombectomy.
Rena brings up a really good point. I think, in the Caribbean, and, this is something that, might be a research paper, pilot that we write, but using tenecteplase in the Caribbean, she and I have talked about this a lot because one of my hospitals uses tenecteplase only. I think it would really be a game changer for the low-income countries. But that's a different talk for a different day because I'm excited about that one. There's a question on the chat that I don't know how to get to. And if you do have a question on the chat on Zoom, you can just unmute and ask the question. I don't think I can access the chat. Okay. You can just unmute and ask, or if you make it bigger, I'll read it. Why not do a CTA at the time of the plain CT? And we do that a lot, actually. We do the CT. The thing is, you have to inject contrast for the CTA, right? So we do the plain CT, and right there on the table, we're prepping for the CTA. So sometimes in that 2 minutes is when we're giving the TPA. So basically, 95%, if not 100% of my TPA that I'm giving is in the CT scanner. Because I get the plain CT, they don't get off the table. I prep the contrast, and if they're eligible for TPA, they're going to get it there. They get the CTA there, and then they get off the table. So my hospital protocol, for example, is a direct to CT. Basically, the ambulance drives up. They have a pit stop at the front. I just make sure that their airway breathing is fine, their blood pressure is fine. Straight to my CT scanner. I have a little pharmacy inside CT with my TPA, and it gets mixed, and they get the bolus right there in the CT scanner. And then the CTA is done like immediately. So before I move from that bedside, I already know what the CT looks like. I already know what the CTA looks like. And like I say, I don't do perfusion as much. Maybe in that 6 to 24 hour window, we'll do it a little bit more. Okay.
Thank you so much, Gillian. My goodness, I think you should be declared a national treasure in Jamaica. Thank you so much. Thank you.